Hello, and thank you for watching this first segment of the lecture on respiratory physiology. This first segment will cover slides number 1 through slide number 79. And the topics that are covered are the first 3 topics listed on the next slide. So this first segment will end by finishing gas exchange, internal and external respiration, and that's slide 79. The second half of the lecture will pick up with topic number 4, shown on the next slide, which is oxygen transport. That's slide number 80. Thanks for watching. In this lecture, we'll start with an overview of the respiratory system and the ways in which the respiratory system contribute to homeostasis. Next, we'll talk about pulmonary ventilation, and that means moving air into and out of your respiratory system. How does that happen? And then we'll look at gas exchange, which is the overall point of the respiratory system. How does carbon dioxide move and how does oxygen move between air that's in our lungs, interstitial fluid, and blood? And then we'll examine oxygen separately from carbon dioxide. These are two different gases. They behave differently and they are carried in different ways by our cardiovascular system. Then we'll talk about how the autonomic nervous system regulates the function of the respiratory system. And along the way, we'll encounter several disorders, including respiratory distress syndrome, pulmonary edema, emphysema, asthma, a pneumothorax, altitude sickness, acidosis, and alkalosis. So these are the basic functions of the respiratory system. Every cell in your body needs oxygen. Every cell in your body except red blood cells. Why don't your red blood cells need oxygen? Anyway, your respiratory system is responsible for bringing oxygen into the body. It's also responsible for excreting or unloading carbon dioxide, a waste product, into the environment. Your respiratory system is the primary homeostatic mechanism that regulates the pH of your blood from moment to moment. And of course, without a functional respiratory system, we would be unable to produce vocalizations. So, this is a very simple diagram of the basic structures of the respiratory system. Much of the respiratory system consists of airways, passageways for air. And in the upper respiratory system, we have the nasal passages and we have the oral cavity. And both the nasal cavity and oral cavity, they both connect to the pharynx. And the pharynx is a fancy word for throat. And the pharynx is divided into 3 regions, not labeled here, but superiorly, we have the nasopharynx. The nasopharynx occurs just posterior to the nasal cavity. And then we have the oropharynx, which occurs just behind the oral cavity. And then we have the laryngopharynx, which occurs in the vicinity of the larynx or the voice box. So those are the 3 regions of the pharynx, and the pharynx is a passageway for both food and air. But when we move into the trachea is a passageway for air only, and the trachea will bifurcate into the right and left primary bronchi or main bronchus as they're labeled here. And then we get into what's known as the bronchial tree. And that is a pattern of branching airways that become more numerous but narrower, leading to the microscopic air sacs called alveoli. Another component of the respiratory system is the musculature. Those muscles include the diaphragm as well as the accessory respiratory muscles like the intercostals, the scalenes. Those skeletal muscles are responsible for modifying the volume of the thoracic cavity that's required for pulmonary ventilation. Here we see a cast of a bronchial tree. So the airways were filled with a plastic-like resin material and the other tissues were digested away. And we can see in the center there, we can see evidence of the trachea and the right and left primary bronchi. And then each bronchus branches to form more numerous but finer airways. Here's a diagram labeling the various airway components that make up a bronchial tree. I'd like you to know about the trachea, the right and left primary bronchi, and then the bronchial tree. And the bronchial tree delivers air to, toward, and away from the alveoli. Not shown here, but those are the microscopic air sacs in the lung. Shown here, we can see a terminal bronchiole leading into a respiratory bronchiole. And bronchioles are airways, and these are just progressively finer or smaller airways. And when we have a respiratory bronchiole, we start to see air sacs, the alveoli. And notice that those alveoli are coated, their surface is coated in pulmonary capillaries. Pulmonary capillaries are capillaries in the lung, and capillaries, all capillaries, are leaky. So if you remember from the cardiovascular system, a capillary wall is very thin, and there are literally holes in that wall to facilitate the movement of material out of the blood and the movement of material into the blood. Well, in the lungs, the two materials that we are most concerned with are oxygen and carbon dioxide. So as blood flows through these pulmonary capillaries, there is the movement of both oxygen and carbon dioxide between alveolar air and blood. Here we see an artistic representation in panel A of what lung tissue looks like using a compound light microscope. And I'll show you a photo of that in just a moment. But let's look at this artistic representation for now. So we're looking at this section for a moment. So this is a slice through a cluster of alveoli, where an alveolus, singular, is one sac, and plural, this is a cluster, a group of alveoli. Alveoli is plural. And each of these alveoli is surrounded by pulmonary capillaries. And you remember that capillaries are the tiniest blood vessels in the body. And so we're going to take this region and blow it up down here. So in panel B, we can actually see the relationship between air that's inside the alveolus and blood that's inside a pulmonary capillary. We see several red blood cells there. And so during exchange, oxygen is going to leave alveolar air and cross this respiratory membrane to move into the blood. And carbon dioxide is going to leave the blood and cross this respiratory membrane to enter the alveolus. And in that way, the composition of air that we've inhaled is different from the composition of air that we've exhaled. Relative to the atmosphere, exhaled air, air that previously occupied alveoli, for the sake of simplicity, that air is going to have a higher concentration of carbon dioxide and a lower concentration of oxygen relative to atmospheric air. And we'll talk about the components of atmospheric air in a little bit. Here we see a photomicrograph. That's a photograph taken through a microscope of lung tissue using a compound light microscope. And over here, we have a fairly large airway, a bronchus. And bronchi are permanently open. They don't collapse because their walls are reinforced with cartilage. So we can see sections of hyaline cartilage here. And the mucosa, the lining of the airways shown here, includes cilia, these hair-like projections of the plasma membrane, as well as mucus-producing cells. And so our airways are coated with this mucus, and that mucus is propelled away from our alveoli by cilia. And that helps trap and eliminate particulates in the air that we inhale. Here we see a smaller diameter airway, and we see a smaller diameter blood vessel. It's not a capillary though, it's not small enough. And then here, let me circle a single alveolus. This is one air sac. And sometimes we can see clusters of air sacs here. And what we can't really see here, we're not on a high enough magnification, are the pulmonary capillaries. So each of these alveoli has several pulmonary capillaries coursing across its surface, and that's where gas exchange will occur. So this is an artistic representation. It's similar to the one that we saw 2 slides previously. I like this one because in this inset, it indicates the directionality of the movement of carbon dioxide and the movement of oxygen. So as blood travels through this pulmonary capillary, oxygen is going to leave the alveolus and move into the blood, and carbon dioxide is going to move out of the blood and into the alveolus. And all of this is by diffusion according to these gases' respective concentration gradients. It's really better to talk about that in terms of partial pressures. But for now, I know you understand concentration gradients. So oxygen and carbon dioxide are moving along their respective concentration gradients by diffusion. Another thing I'd like to point out on this slide is the structures that make up the respiratory membrane. So here, the respiratory membrane. The respiratory membrane is the set of structures that a gas molecule, like oxygen or carbon dioxide, the set of structures that a gas molecule must traverse in order to move between blood and alveolar air. So you remember, I hope, that the wall of blood vessels, the lining of blood vessels is endothelium. And endothelium is simple squamous epithelial tissue, these really thin, flat cells. Well, these thin, flat cells make up the wall of a pulmonary capillary as well. No surprise there. So here we see capillary endothelium. And then every epithelial tissue has a basement membrane. That's a non-cellular layer. So this endothelial tissue has a basement membrane. It's actually an incomplete basement membrane. There are holes in it. And then let's go from the opposite direction, the lining of the alveoli. So the alveolar wall is also made up of simple squamous epithelial tissue, very thin, flat cells. And moving inward from that, or moving deep to that, I suppose, we also have a basement membrane. So we have the alveolar cells, which are thin and flat, like simple squamous epithelial cells. And then that epithelial tissue also has its basement membrane. So these are the 4 structures that make up the respiratory membrane. And they are all, by design, thin, which makes it easier and faster for oxygen and carbon dioxide to cross. And I'm emphasizing this respiratory membrane right now because it becomes important when we talk about the severe effects of COVID-19. And down the road, I'll tell you a bit more about pulmonary edema and how that affects this respiratory membrane. The variety of airways shown here can be divided into 2 basic categories, the conducting zone and the respiratory zone. So structures that form the conducting zone, like the right and left primary bronchi, the bronchioles, the terminal bronchioles, they simply, and I'll say simply for now, they simply allow air to flow through them. There are no alveoli associated with the airways that make up the conducting zone, and therefore no gas exchange occurs. They're just passageways for air. They do more than that. I'll tell you more about that in a moment. The respiratory zone, which is made up of the very finest airways, is where gas exchange occurs because there are alveoli. So the first place we start to see alveoli in the bronchial tree is in the respiratory bronchioles. And the presence of alveoli allows for gas exchange in the respiratory zone. So the conducting zone, this passageway where no gas exchange occurs, it is a passageway and no gas exchange occurs, but it also serves a few other functions. So our airways are lined with a mucosa and epithelial tissue that is ciliated. Cilia are hair-like extensions of the plasma membrane, and these cilia are coated with mucus, this sticky material. And so in the conducting zone, the mucus-coated cilia help to trap and propel particulates away from our alveoli. The alveoli are pretty delicate. They're very delicate tissues. And we want to keep particulates out of our lungs. And so these alveoli will beat rhythmically and propel that mucus and anything trapped in it towards our oropharynx, where we might swallow it. And so it will go down our esophagus and land in our stomach. And in our stomach is way better than in our lungs. These conducting airways also serve to warm up inhaled air and to humidify it. So the relative humidity of air that's inside of our alveoli, it's 100% humidity in there. And so gas exchange occurs across wet surfaces. And so that air necessarily needs to be very, very humid. And so as that air is passing through our conducting zone, it gets heated up necessarily because our bodies are warm. And here in San Francisco, our bodies are frequently, often, most of the time, fortunately, warmer than ambient air temperature. And of course, our conducting zone is also responsible for our ability to make vocalizations and the characteristics of a particular voice, whether it's high and nasally or maybe it's low and resonant. That has to do with the three-dimensional structures of the conducting zone. Your lungs are encased, they're enveloped in a double serous membrane called the pleura. And a serous membrane is a membrane that lines body cavities that don't open to the external environment. So think about your thoracic cavity, right? You might think that it opens to the external environment because you have a nose and a mouth, but it really doesn't. The lungs are surrounded by the pleura, and it's a double-walled membrane. And the layer that sits atop the lung tissue itself, that's called the visceral pleura. And it's continuous with the parietal pleura. The parietal pleura lines the interior, the inner wall of your thoracic cavity. And these are very thin membranes, and they produce a serous fluid, which acts as a lubricant. So as your lungs inflates and deflates, the pleura are able to rub against each other in a way in which they are not harmed because the serous fluid is very lubricating. And I mentioned that the parietal pleura is continuous with the visceral pleura. So you could trace the parietal pleura and the visceral pleura without ever lifting your pencil off the paper. Let's try it. So we can start with the visceral pleura. So now I'm on the exterior surface of the lung. Now I'm on the exterior surface of a bronchi. And now we're part of the parietal pleura. And we can keep going around until we once again become part of the visceral pleura. So I put this vocabulary list here as a check for me and for you. Did we talk about each of these structures in a meaningful way? Oh, I see a vocabulary word that I did not use. That lubricating fluid, that serous fluid that I mentioned in the previous slide that occurs between the visceral and the parietal pleura, the technical term for that is intrapleural fluid. That's a very specific term. It's the fluid that occurs between the visceral and parietal pleura, and it's a lubricant. Everything else I think we've talked about. We're covering the respiratory system. So here's a definition of respiration, the process of gas exchange in the body. And the term respiration has two meanings in biology, and it's usually clear from the context of the paper or the conversation which one we're talking about. But I'll clarify here to avoid confusion for you possibly down the road. So cellular respiration is not what we're talking about right now. We have in the past. We talked about cellular respiration in the muscular system. Cellular respiration refers to the processes that a cell uses to make ATP. That's not what we're discussing here in the respiratory system. Rather, in the respiratory system, we're discussing the process of gas exchange, and respiration occurs in these 5 stages. We'll talk about pulmonary ventilation. That's how air enters and leaves the respiratory system. And then we have gas exchange occurring two places. The first place is gas exchange that occurs in the lungs between blood in pulmonary capillaries and air in alveolar sacs. And that gas exchange that occurs in our lungs is called external respiration. And then transportation refers to the forms in which these gases are carried as they're moved by our blood all around the body. How is carbon dioxide carted around? How is oxygen carted around? And then we have internal respiration. That's our second site of gas exchange. And during internal respiration, there's an exchange of material between blood in a systemic capillary and a body tissue. And then finally, the whole purpose of the respiratory system is because our cells need to use oxygen and they generate carbon dioxide as a waste product. In this diagram, we can have a visual reinforcement of the 5 components of respiration. So component number 1 is pulmonary ventilation. Pulmonary ventilation is shown here. We'll talk much more about that in just a moment. That's the movement of air into and out of the respiratory system through that conducting zone into the respiratory zone. And component number 2 is external respiration. That's gas exchange that occurs in the lung. And here we can see that exchange is occurring between blood that's in alveolar air, between alveolar air and blood that's in a pulmonary capillary. And then our third component is gas transport. And that refers to the form in which carbon dioxide travels in the blood, the form in which oxygen travels in the blood. And we'll go into detail down the road. And then the fourth component of respiration is gas exchange that occurs in the tissues. And this is also known as internal respiration, where we have the movement, the exchange of materials between blood that's in a systemic capillary and a body tissue. And then component number 5 is cellular respiration. Oh, there's that word again. But now you know cellular respiration is referring to the process by which these cells are making ATP. And this process uses oxygen and it generates carbon dioxide. And this is the whole reason why we require a respiratory system and a circulatory system to constantly deliver oxygen to our tissues and to cart away carbon dioxide. Moving on to pulmonary ventilation. That's the mechanism by which air moves from the atmosphere into your respiratory system and from your respiratory system into the atmosphere. And air will always move along a pressure gradient from an area of high pressure to an area of low pressure. And the way your respiratory system works is predicated upon this basic physics. So in physiology class, we typically use these 2 units to express air pressure, millimeters of mercury or atmospheres. I'll try to use them both so that you become comfortable with both units. And a good thing to know is that 1 atmosphere is equal to 760 millimeters of mercury. And millimeters of mercury is an older unit, but it's still used in physiology and health and medicine. And the name millimeters of mercury comes from the device initially developed to measure pressure. And the measurement is what pressure is required to raise a column of mercury, similar to an old-fashioned thermometer. What pressure is required to raise a column of mercury by a particular number of millimeters. So atmospheric air near sea level is 1 atmosphere or 760 millimeters of mercury. And so if that's the air pressure in the surrounding atmospheric air, what do we need to achieve in order to get that air to flow into our respiratory system? Well, remember that air always flows from an area of high pressure to an area of low pressure. So in order to get the air to flow into the respiratory system, we need to generate a lower pressure inside our respiratory system. And we generate that lower pressure by increasing the volume of the thoracic cavity. In this diagram, you can see that the diaphragm, which is the major respiratory muscle, the diaphragm is contracting, and that means this dome-shaped muscle is flattening out, and by flattening out, it's increasing the volume of the thoracic cavity. But when we get roomier in here, that means there's space for the air molecules that are already here. Those air molecules can get farther apart from each other. And that goes hand in hand with a decrease in the pressure inside the thoracic cavity. And so let's look at this question. What pressure must be achieved inside the lungs in order for air to flow into them? In order to inhale, what air pressure do we need to achieve in the thoracic cavity? Anything that's below 760. So 759 millimeters of mercury will do it. So in this diagram, we have some of the values filled in. The pressure inside the alveoli here, 758 millimeters of mercury, and then intrapleural pressure is even lower at 754. And so it's this 758 that allows air to move from an area that's 760 toward an area that's 758. Air flows from an area of high pressure to an area of low pressure. In this case, the respiratory muscles generated a lower pressure in the thoracic cavity, and that's inhalation. Next question. What pressure must be achieved inside the lungs in order for air to flow out of them? Now we need to exhale. We need to generate a pressure gradient in order to get air to leave our lungs. And so atmospheric pressure hasn't changed at all. It's still 1 atmosphere, or 760 millimeters of mercury. What pressure do we need to generate inside the thoracic cavity in order for air to flow from an area of high pressure to an area of low pressure? Well, if you said 761, you'd be correct. So here's a similar diagram with those values shown. So alveolar pressure during exhalation is 762 millimeters of mercury. That's enough of a pressure gradient to get the air to flow from an area of high pressure to an area of low pressure. And what causes that pressure change? Mainly the movement of the diaphragm. So here we see the diaphragm relaxing. As it relaxes, it pops back up and it decreases the volume of the thoracic cavity. So now there's less space in the thoracic cavity, and those air molecules get closer together, and that goes hand in hand with a rise in pressure. And that pressure is sufficient to create a gradient, and we call that exhalation. So pulmonary ventilation works by these alternating pressure gradients during inhalation and then exhalation and then inhalation and then exhalation. And those alternating pressure gradients are ultimately generated by muscles, respiratory muscles, that can change the volume of the thoracic cavity. The primary respiratory muscle is the diaphragm. The diaphragm is a dome-shaped, sheet-like muscle that forms a physical, airtight, liquid-tight barrier between your thoracic cage and your abdominopelvic cavity. The diaphragm is a major landmark in the body because it separates these two major body cavities, the thoracic cavity from the abdominopelvic cavity. And this diagram is very similar to ones that we just went over, but you can see this is a respiratory cycle. So a respiratory cycle is that repeating pattern of inhalation followed by exhalation, followed by inhalation, followed by exhalation. And it's largely generated by the diaphragm. We have accessory respiratory muscles that further expand or compress the thoracic cavity to move even more air in or out by generating an even steeper pressure gradient. And so on the left side of this diagram, with all of these up arrows here, these muscles are all involved with aiding inspiration or inhalation. When these muscles contract, muscles like the sternocleidomastoid, the scalenes, and the external intercostals, when these muscles contract, they draw the rib cage upward and outward. And this further increases the volume of the thoracic cavity, which creates an even steeper pressure gradient, which allows more air to flow into the respiratory system. And then on the right side of the diagram, these muscles here that all sort of have the down arrow, these are accessory respiratory muscles that are important in forced exhalation. So when these muscles contract, they pull the ribs, they make the thoracic cavity get even smaller in volume. And that generates an even steeper pressure gradient, which causes even more air to leave the respiratory system and join atmospheric air during forced exhalation. So quiet breathing is what happens when the body is at rest. You are perhaps engaged in quiet breathing right now. You're not engaged in physical activity. You're not particularly anxious. You're not laughing. You're not singing. You're just sitting there watching this lecture and breathing. That's quiet breathing. And the primary drivers of quiet breathing are your diaphragm and your external intercostals. And those muscles are enough to move roughly half a liter of air into and out of your lungs during a respiratory cycle. And then anything beyond quiet breathing is known as forceful breathing. So if you were to get up and become physically active, your inhalation and exhalation would get a little bit bigger. Some more air would be moved. If you were to yawn or sneeze or cough or start to sing or speak for that matter, more air in addition to your tidal volume that's moved during quiet breathing, more air will be moved during what's known as forced breathing. I hope you recognize this diagram because we looked at it during the spirometry activities in the lab. And this is what we were talking about a moment ago. This is tidal volume. This is the amount of air that moves in and out of your respiratory system during quiet breathing, and it's roughly 500 milliliters. And then anything beyond that, anything beyond quiet breathing is considered forceful breathing. And maybe you'll recall that when you take an inhalation beyond your normal tidal inhalation, that's called your inspiratory reserve volume. And when you take an exhalation beyond your quiet exhalation, that's called your expiratory reserve volume. And maybe you remember that your vital capacity is the total volume of air that you can inhale and exhale. And I hope you also remember that there's always some volume of air that is impossible to exhale. So when we add these volumes together, your inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume, we get your total lung capacity. And these are average values shown here for a male body and a female body. So quiet breathing is driven primarily by the diaphragm with some help from the external intercostals, and those external intercostals pull up the ribs to expand the volume of the rib cage. And then forceful breathing requires additional activity of accessory respiratory muscles. So your internal intercostals, which will pull down on your rib cage, the rectus abdominis, the external and internal obliques, the transversus abdominis, the pectoralis minor, the sternocleidomastoid, and the scalenes. If you've taken anatomy, you, I hope, remember these muscles, and all of these muscles here further aid in changing the volume of the thoracic cavity beyond what the diaphragm and the external intercostals can do. Beyond these muscles, there are many other factors that influence the movement of air into and out of the lungs, and we'll talk about each of these. Let's start with elastic recoil. So elasticity is the tendency to spring back after stretching. So this rubber band is a great example of an elastic material. You stretch it, and if you let that rubber band go, you know it will snap back to its original length. Let's think about the amount of spring back. How much does that rubber band spring back if that rubber band is stretched weakly? You don't stretch it too much, you stretch it weakly. Well, you'll get a weaker snapback, right? What about if you stretch that rubber band a lot, you really pull on it, where you're going to get a more forceful snapback? That's also a property of elasticity, and it's a property of your lungs and your chest wall. So in your chest wall, as well as in your lungs, you have these protein fibers known as elastic fibers, and they exhibit this physical property known as elasticity. So if you go ahead and take a big inhalation, at your next exhalation, the elastic recoil of your lungs and the chest wall will contribute to changing the volume of the thoracic cavity as that chest wall snaps back. That helps with exhalation. Another thing that helps with the elastic recoil is surface tension that's between the air and the fluid that's lining your alveolar sacs. We'll talk more about that. All right, so I chose this diagram because the artist was careful to include elastic fibers. These are stringy proteins that exhibit elasticity. If you stretch them, they will snap back. And we find these elastic fibers both in the lung tissue itself as well as in the tissues that make up the wall of your chest. And surface tension. We have not yet had an opportunity to talk about surface tension this semester. It's quite important in the respiratory system. So here we're looking at several alveoli, and we can see, I'll pick a different alveolus here. Here we have those simple squamous epithelial cells that make up the alveolar wall. They're very thin, they're part of that respiratory membrane. Well, they're lined with a very thin layer of fluid known as alveolar fluid. That's a good name for that. And that alveolar fluid is a body fluid. It's mostly water with a variety of dissolved solutes. And the composition of that alveolar fluid determines the surface tension present here. And so to explain surface tension, I'll move over to a non-biological example. So here we're looking at a drop of water on the surface of a car. So maybe it's just rained and there are beads of water on the hood of the car or the window. And the reason why water beads up like that, it doesn't stay in a flat sheet, but rather it forms beads, is because of this property known as surface tension. And surface tension arises at any interface, anywhere where a liquid meets a gas, right? And on the surface of that car, there are water molecules and there are air molecules. And so that's where a liquid meets a gas. And it turns out, I hope you remember that water plays the magnet game. Water molecules attract each other. The water molecules are more attracted to each other than they are to the gas molecules, than they are to the atmosphere. And so that attraction between neighboring water molecules, particularly on the surface at the liquid-gas interface, that attraction between neighboring water molecules, here that attraction is shown in red, gives rise to surface tension. And so those water molecules really want to stay together. They don't want to spread apart from each other. That's surface tension. Here's an organism that makes its living relying on surface tension. This is a water strider, and it relies on surface tension to skate around on the liquid surface of water, hunting for prey and looking for mates. It doesn't sink because the water molecules at the gas liquid interface, those water molecules are particularly attracted to each other. And that allows the water strider to stay on top of the water without breaking the surface tension. Okay, back to the respiratory system. So lining the alveoli, we have this alveolar fluid and we have a gas liquid interface. The gas is alveolar air and the liquid is alveolar fluid, and that's mostly water. And so that alveolar fluid's going to have surface tension. The water molecules are going to be extra sticky for each other. They're not going to separate from each other easily. And that's going to influence both expansion of the alveoli as well as contraction or deflation of the alveoli. How sticky are those water molecules for each other? How strong is the surface tension? Well, following inhalation, surface tension contributes to the elastic recoil of the wall. During inhalation, those water molecules that are part of alveolar fluid, they get pulled away from each other and they're ready to snap back because of that surface tension. And that snapback due to the surface tension is part of the elastic recoil that occurs during exhalation. Let's think about it from the other process. Let's think about the beginning of an inhalation. We want those alveoli to expand, but because of that surface tension, those water molecules are harder to pull away from each other. So this surface tension that's present in alveolar fluid opposes inhalation. It actually makes it harder to inhale. So the surface tension of alveolar fluid is something that's regulated. The surface tension, if it's too high, it makes inhalation impossible. And if it's too low, it makes inhalation very easy, but it makes that elastic recoil insufficient. So natural selection has to strike this balance. What's just the right surface tension where it's easy enough to inhale, but there's enough surface tension to have that elastic recoil during exhalation. And so to achieve that balance, that perfect surface tension that serves both purposes, alveolar fluid contains surfactant. In biology and physiology, we just refer to this stuff as surfactant, but there are surfactants that exist in non-biological contexts, and we use them to reduce surface area. Your dishwashing detergent, Dawn or Palmolive or whatever you have, contains a surfactant. And so let's pretend that this is dishwasher detergent in some water, and there's the air-liquid interface. So we see these water molecules in red and white, and we see our surfactant molecules. Oh goodness, that looks like an amphipathic molecule. Why, yes it is. Amphipathic, I'll remind you, means part of the molecule is hydrophilic and part of the molecule is hydrophobic. So this surfactant shown here is able to situate itself in between neighboring water molecules. So the surfactant, let's just take this trio here. The surfactant is going to disrupt the attraction between these two neighboring water molecules. And so the surfactant is reducing the surface tension of this liquid. The same thing applies in alveolar fluid. Now we can revisit this diagram, and I'd like to point out that in this diagram, the artist was careful to include alveolar fluid. That's the fluid that lines the air sacs in the lung. It's mostly water with a variety of dissolved solutes, and one of those dissolved solutes is surfactant, and surfactant reduces the surface tension of alveolar fluid. So because of surfactant, the surface tension of alveolar fluid is enough to contribute to the elastic recoil, but it's not so strong to inhibit or prevent inhalation. The absence of surfactant in premature babies gives rise to what's known as respiratory distress syndrome, or RDS. It's a very common complication of a premature birth. So surfactant in alveolar fluid is not produced in a developing fetus until the very end of pregnancy, right? The fetus is not going to use its lungs, so there's no reason for it to start to produce surfactant. And so with a preterm birth, the premature infant often has difficulty taking its first inhalation because without that surfactant, the surface tension of alveolar fluid just can't be overcome by the respiratory muscles of this newborn infant. And so, fortunately, today it's pretty easily treated, and it's treated by delivering an exogenous surfactant into the newborn's lungs. And so exogenous, if you remember the meaning of that word, exogenous means it comes from outside the body. So the baby's not making enough of its own surfactant. So if we give it some exogenous surfactant, that allows the baby to take its first breaths. The second factor affecting the movement of air into and out of the respiratory system is called compliance. And compliance refers to how easily the lungs and the chest wall can expand. So when we talk about high compliance, that means that the lungs and the chest wall expand quite easily. And then we can have a low compliance where it requires a lot of effort to expand the lungs and the chest wall. You probably have some experience with high compliance balloons versus low compliance balloons. So a high compliance balloon is a balloon that blows up very easily. It's not difficult for you at all. And a low compliance balloon is that balloon where you huff and puff and your cheeks get sore and it's very difficult for you to inflate the balloon. That's a low compliance balloon. So in the respiratory system, you can easily imagine that low compliance is a problem. It's harder for pulmonary ventilation to occur, particularly for inhalation to occur in a low compliance system. So what are some factors that might cause low compliance in the respiratory system? Here are 3 factors that can lead to low compliance. The first one we just talked about in respiratory distress syndrome that's common among premature infants. And those premature infants don't produce enough surfactant. And without enough surfactant, the surface tension of alveolar fluid is too high. Those water molecules are too sticky for each other, and it makes it difficult, if not impossible, for the infant to take their first inhalation. So that's due to low compliance because there's not enough surfactant. Number 2 and number 3 are new for us: pulmonary edema and emphysema. So pulmonary edema has come up a little bit before. We talked about pulmonary edema in the context of congestive heart failure. And edema, you'll recall, is the buildup of interstitial fluid, and pulmonary edema is just edema, but in the lungs. And it can be life-threatening. Pulmonary edema is bad for a couple of reasons. Number 1, this excess interstitial fluid inside the alveoli, that can dilute the surfactant. It can water down the surfactant that's part of alveolar fluid and lead to an increase in surface tension. And that leads to a decrease in compliance. It's more difficult to inhale due to this higher surface tension inside the alveoli. We can overcome that using a mechanical ventilator. So we're no longer relying on the patient's muscles for pulmonary ventilation. We're relying on a machine for pulmonary ventilation. But there's a second problem with pulmonary edema, that we don't have a machine that can overcome that. And it's an increase in the diffusion distance. So this isn't the best image for reviewing the respiratory membrane or talking about diffusion distance, but I'm going to use it anyway. And I'll start by drawing in, I'll use purple here, and I'll just draw a pulmonary capillary. And that pulmonary capillary is crossing along an alveolar sac. And I'll remind you, let me switch to green here, that there's a respiratory membrane. The respiratory membrane is composed of a set of structures that a gas molecule, like oxygen, needs to pass through in order to get out of alveolar air and into the pulmonary capillary. Well, this alveolus, this alveolar sac, is flooded with interstitial fluid because this person has pulmonary edema. So now the distance that the oxygen molecule needs to diffuse, it's called the diffusion distance, the physical distance that that oxygen molecule needs to diffuse in order to get out of alveolar air and into the pulmonary capillary, that distance has become much greater because there's this body of fluid in the way. And it turns out that that interstitial fluid is mostly water, and oxygen is not particularly soluble in warm water. It does not dissolve easily in warm water. So that presents a barrier for what's known as oxygen loading. Oxygen loading is the movement of oxygen from alveolar air into the blood. It's how blood becomes oxygenated. And during pulmonary edema, oxygen loading, it can be severely compromised and it can be a cause of death. And that's what's happening in some of the more severe cases of COVID-19. We put the patient on a ventilator to take care of the pulmonary ventilation and the low compliance, but we just don't have an effective way to treat in all cases pulmonary edema, preventing adequate oxygen loading. Another factor that can lead to a low compliance situation is a disease known as emphysema. Emphysema, the most common cause of emphysema is smoking tobacco, but also chronic exposure to other lung irritants, like in coal miners, for example, can lead to emphysema. And emphysema is a chronic and it's a progressive disorder. So chronic means you have it for a long time, and progressive means it tends to get worse over time. And in emphysema, these particulates that get into the lung tissue that shouldn't be there, these particulates lead to the formation of scar tissue, and they lead to the destruction of alveolar walls. In this image, we can compare normal alveoli down below with the alveoli that we observe in someone with severe emphysema. So in destroying the alveolar walls, we now effectively reduce the surface area for gas exchange. Oxygen loading, carbon dioxide unloading, that external respiration, right? That's gas exchange in the lung. That all occurs across a surface. The more surface you have, the more opportunity there is for exchange. Well, in the patient with severe emphysema, there's far less surface area. So oxygen loading is also hampered, as it is in pulmonary edema, but for very different reasons. Here's an old Superman cartoon, a public service announcement. With my amazing X-ray vision, I can see the harm cigarettes do inside people's bodies. That's why I don't smoke. I love this photograph. I want to be this lady when I grow up. So maybe you love someone who has emphysema. Maybe you've seen people walking around with these portable oxygen tanks. Because oxygen loading is inhibited, it happens more slowly, and someone with emphysema, they need to breathe air that is supplemented with oxygen, and that will make oxygen loading a little easier. We'll talk about concentration gradients, we'll talk about partial pressures to be more specific. But breathing air that is enriched with oxygen makes oxygen loading happen faster. Just a reminder about where we are. We've been talking about factors that affect pulmonary ventilation. And many slides back, there is a slide that lists them 1, 2, 3, 4. Elastic recoil, surface tension, compliance, and here we are at number 4, a factor that affects the movement of air into and out of the respiratory system, and that's airway resistance. And airway resistance is analogous to vascular resistance. If you remember, in vascular resistance, that has to do with blood flow through a blood vessel, but here in the respiratory system, we're talking about airway resistance. So it's airflow through an airway. And what they both have in common is that it is an impeding force to flow that's caused by the friction between what's flowing through the tube and the wall of the tube itself. So in this case, for airway resistance, it's friction between the air molecules, and the wall of the airway itself. And just like with vascular resistance, airway resistance is influenced by the diameter of the tube. And so by changing the diameter of the airway, we can increase or decrease airway resistance. So here we're looking at two airways. The one on the left is in a state of bronchodilation, and the one on the right is in a state of bronchoconstriction. Notice the diameter of the lumen of each. And so which airway exhibits less resistance and therefore greater flow? It is the airway on the left. There is lower airway resistance in a wider diameter airway. Airway resistance is regulated by the autonomic nervous system. And we've seen this table before. And let me remind you, there are two branches of motor outputs in the autonomic nervous system: sympathetic motor output and parasympathetic motor output. And most of the effectors in the autonomic nervous system receive dual innervation. So they receive stimulation via sympathetic motor neurons, and they can also receive stimulation from parasympathetic motor neurons. Let me also remind you about the paradigm that we can use to keep the overall effects of sympathetic separate from the overall effects from parasympathetic. And that was the fight or flight versus rest and digest paradigm. And these are both extreme versions of sympathetic versus parasympathetic stimulation. And in reality, your body is constantly fluctuating between the two all day long. So let's think about fight or flight. What's needed in extreme activation of the sympathetic nervous system in a flight or fight scenario? We would expect bronchodilation. We need to reduce airway resistance so that pulmonary ventilation becomes very, very easy, with the anticipation of a sharp increase in physical activity as you prepare to run or to fight. And so with an increase of sympathetic stimulation to the smooth muscle that occurs in the walls of airways, that's going to lead those smooth muscles to relax and cause bronchodilation. So those airways get wider and airway resistance goes down, and it makes pulmonary ventilation easier. And then we can think of the other extreme, rest and digest. That's going to call for an increase in parasympathetic stimulation. And so we can go back to our picture of it's just after the Thanksgiving meal and you're not responsible for cleaning up and you're not responsible for any children or pets. That's extreme activation of the rest and digest or the parasympathetic response. And so under those circumstances, it's okay for bronchoconstriction to happen. It's fine for there to be an increase in airway resistance because your body is, except for your GI tract, the rest of your body, your skeletal muscles, are at rest. And with that increase in airway resistance, that's totally fine. Pulmonary ventilation is adequate because there are reduced demands for oxygen in skeletal muscles relative to the opposite, that sympathetic, that fight or flight response. Continuing with the autonomic nervous system, we see terms that should be familiar to you. I hope you remember that signaling molecules involved in sympathetic motor output include norepinephrine as well as epinephrine. And these signaling molecules are associated with sympathetic motor output and lead to bronchodilation, as shown on the left here. And then acetylcholine is secreted by parasympathetic motor neurons, and acetylcholine is associated with bronchoconstriction, as seen on the right here. Asthma is probably the most common respiratory disorder. We all love somebody who has asthma. And here are some of the symptoms of asthma. Asthma includes wheezing. So when the person just breathes, we can hear a wheezing sound. They might report a tightness in their chest or a shortness of breath. And what's going on in the asthmatic is there might be inflammation in the airways, and couple that with bronchoconstriction. So that can dramatically increase airway resistance. I'll show you an image in a moment. Like many disorders, asthma varies from mild to severe. And in the severe asthmatic, an asthma attack can be life-threatening. And whether or not a person has asthma, it's not thoroughly understood, but it seems to be caused by a combination of genetic and environmental factors. People who live, or children particularly, children who live in higher air pollution areas are much more likely to present with asthma than children who live in low air pollution areas. So here we're looking at the airways of a person with asthma, and on the left we see the airway just prior to the onset of an asthma attack. So during an asthma attack, immune system cells release signaling molecules that cause a local inflammation and bronchoconstriction, as well as an increase in mucus production. So with some forms of asthma, an asthma attack can be triggered by allergens, particulates in the atmosphere that induce this immune system response. And notice here, down here, in this supporting text, it says natural killer cells release cytokines in response to allergens, triggering inflammation. The air passages become inflamed and mucus filled. So cytokines, perhaps you've heard about a cytokine storm in the context of COVID-19. Cytokines are a very diverse group of signaling molecules, and many of them, not all of them, but many of them are immunomodulators, meaning immune system cells respond to them, and immune system cells are responsible for the inflammatory response, inflammation. And typically inflammation is a good thing. It's part of the healing process. We've all observed inflamed tissues. You slice your hand on a knife, you twist your ankle, some part of you gets swollen. That's evidence of inflammation. And inflammation is good when it serves to deliver more oxygen, more nutrients, more white blood cells, all of which are required for the healing process. But inflammation can be a bad thing when it runs away from us. When there's too much inflammation, it can deliver too much blood and lead to edema, for example, can lead to pulmonary edema, like we talked about a few slides ago. Here, we're thinking about the person with asthma, and pulmonary edema is not generally associated with asthma, but rather, as we can see in this image here, these immune system signaling molecules can lead to bronchoconstriction, so a narrowing of the diameter of the airway, coupled with an increase in the production of mucus. And so in the airway on the right here, we have very high airway resistance, and this can be life-threatening. Pulmonary ventilation is insufficient to sustain life. Continuing to think about the person that has asthma, how do they manage the disease? What therapeutic avenues are available? And the therapies for asthma are divided into these two categories, daily management and rescue relief. So daily management means what do we do day to day to reduce the symptoms of asthma and to prevent an asthma attack. And so daily management typically includes avoiding known triggers. So this might mean that the person avoids going outdoors on days where the air quality is poor, for example. And daily management might also include regular inhalation of an anti-inflammatory drug, just to keep the inflammation in the lungs low, to keep those airways relatively open. And then rescue relief, that's a measure that's taken at the beginning, hopefully at the onset of an asthma attack. And rescue relief therapy involves drugs that induce bronchodilation, drugs that increase the diameter of the airways. So here's a child using their rescue relief inhaler, and that inhaler includes or delivers bronchodilator directly into their lungs. And that bronchodilator might be a beta-2 agonist, or it might be an anticholinergic. So a beta-2 agonist, here's an example, is albuterol. So what a beta-2 agonist does is it mimics epinephrine and norepinephrine. So you remember that word agonist. An agonist is a competitor for a signaling molecule. And when that agonist binds to the receptor, just like the original signaling molecule, it also activates the receptor and brings about the change in the cellular behavior. So these beta-2 agonists act like epinephrine and norepinephrine, and they induce bronchodilation, just the way the sympathetic nervous system would cause bronchodilation. The other type of rescue relief inhaler might be an anticholinergic. Anti means against, right? Cholinergic refers to acetylcholine. So an anticholinergic is an antagonist for acetylcholine. So the example there is Atrovent. That inhibits the effects of acetylcholine. And if you recall from a few slides back, acetylcholine causes bronchoconstriction, right? That was the rest and digest parasympathetic output. So if we can inhibit or prevent the effects of acetylcholine, we can limit the degree of bronchoconstriction and accentuate the bronchodilation. Our next disorder is called a pneumothorax. And a pneumothorax is a hole in the chest wall that often causes a lung to collapse. So when there's a hole, such as from a gunshot wound or a stab, when there's a hole in the chest wall, that allows atmospheric air to move into the thoracic cavity. So it's exterior to the pleura, and it's between the pleura and the chest wall. And that causes a rise in air pressure, intrathoracic pressure, and the alveoli deflate. This is also known as a collapsed lung. And sometimes it's referred to as a sucking chest wound. So these patients, you can hear them breathe, and the noise isn't coming from their mouth, but the noise is coming from their wound. With every inhalation and exhalation, they're changing the pressure inside their thoracic cavity, only now they have this artificial opening, the sucking chest wound, and so air can move in and out across the wall of their chest, and it's called a sucking chest wound because of the noise that it makes. On this x-ray, we can see evidence of a collapsed lung, a pneumothorax. And so if we look at the normal lung in this image, as we just look at this picture, the normal lung is on the right side of this picture. And we can see evidence of a bronchial tree here. It's a nice bronchial tree, but if we look at the other lung, we don't see evidence of the bronchial tree, and that's because the lung is collapsed. And the quickest way to treat a collapsed lung is to evacuate the atmospheric air that is here. And when we evacuate that atmospheric air, we cause a decrease in intrathoracic pressure, and that allows that lung and those alveoli to inflate easily. In the next segment, we'll talk about gas exchange. And I'll remind you that gas exchange occurs 2 places in our body. During external respiration, gas exchange occurs in our lung as oxygen and carbon dioxide move between alveolar air and blood in the pulmonary capillaries. And then during internal respiration, gas exchange occurs in our body tissues as oxygen and carbon dioxide move between blood that's in a systemic capillary and interstitial fluid that's part of a systemic tissue. I like this diagram because the gases are color-coded here. And we can use these color-coded gases to remind ourselves about external respiration and internal respiration. So in both panels, the top and bottom panel, carbon dioxide is yellow and oxygen is green. And during external respiration, shown up here, during external respiration, this is gas exchange that occurs in the lung, and oxygen is going to leave alveolar air and enter blood in a pulmonary capillary. Simultaneously, carbon dioxide is going to leave blood that's in a pulmonary capillary, and it's going to join alveolar air. And then as we move into body tissues, we have internal respiration. Internal respiration happens between a body tissue and blood that's in a systemic capillary. And so we have our two color-coded gases again. And during internal respiration, oxygen is going to leave the blood and enter the body tissue. And carbon dioxide is going to leave the body tissue and enter the blood. And in all cases, whenever oxygen or carbon dioxide move, it's always based on a gradient. You remember that nature abhors a gradient, and a substance is always moving from an area of high pressure, for example, to an area of low pressure, or from an area of high concentration to an area of low concentration. So let's talk about the composition of atmospheric air. So the air that we breathe is mostly nitrogen. And nitrogen is largely inert. So we're inhaling nitrogen all the time, we're exhaling nitrogen all the time. As far as we know, that nitrogen plays no role in our physiology other than comprising the majority of atmospheric air. The next most abundant substance that's in atmospheric air is molecular oxygen, O2. It makes up about 21% of atmospheric air. And then notice that there's a giant gap there. Carbon dioxide makes up 0.04% of atmospheric air. There's also water vapor and several other gases in small quantities. These are things like helium, for example, argon. So in the respiratory system, we've been talking about air pressure, right? And you remember that air is always going to flow from an area of high pressure to an area of low pressure. And we're also going to think in terms of concentration gradients. But first, when we are talking about a mixture of gases, and that's what atmospheric air is, it's a mixture of gases. It's mostly nitrogen with a lot of oxygen and a little bit of carbon dioxide and smaller amounts of other things. How do we express the relative concentrations of these different gas components of this mixture? Well, we use partial pressure. And you can think about partial pressure as the pressure exerted by that one particular gas in a mixture of gases. And the way we write it is a capital P and then a subscript of the particular gas or of the particular molecule we're talking about. So we have the partial pressure of nitrogen, we have the partial pressure of oxygen, the partial pressure of carbon dioxide written here. So if total atmospheric pressure at sea level is 1 atmosphere or 760 millimeters of mercury, we can think about the partial pressure of each of the gases that make up that mixture known as atmospheric air. So the partial pressure of nitrogen, for example, is the portion of atmospheric pressure that's attributable to nitrogen. So what proportion of this 760 is due to the presence of nitrogen? What proportion of 760 is due to the presence of oxygen, and on down the line? In this table, we see gas listed in order of abundance. So the most abundant gas is nitrogen, followed by oxygen, water vapor, carbon dioxide, and other gases. In the second column, we see what percentage of the atmosphere is comprised of that particular gas. So here, 78.6% of atmospheric air is nitrogen, 20.9% is oxygen, and so on down the line. And when we multiply that percentage by the total atmospheric pressure, we get the partial pressure for each of these gases. So the partial pressure of nitrogen in atmospheric air is 597.4 millimeters of mercury. So of that 760 total atmospheric air pressure, 597.4 millimeters of mercury are attributed to the pressure generated by the molecules of nitrogen. And so notice when we add up all these partial pressures, 597 plus 158 plus 3 plus 0.3 plus 0.5, when we add these up, when we sum them, notice that we get total atmospheric pressure, 760 millimeters of mercury. So during gas exchange, oxygen and carbon dioxide are going to move according to their respective partial pressure gradients. It's analogous to thinking about a concentration gradient, but we're thinking about gases now. And so we use the terminology partial pressure. And any gas is going to move from an area of high partial pressure to an area of low partial pressure. You can also think about this as a gas moving from an area of high concentration to an area of low concentration. Only the proper terminology is partial pressure. Here we can examine values for the partial pressures of carbon dioxide and oxygen. Those are our two gases of interest. We can look at the partial pressures for these two gases at various locations that are related to the respiratory system and the cardiovascular system. So what are the partial pressures of these gases in atmospheric air? We can also examine the partial pressures of these gases in alveolar air. And now we're moving into the cardiovascular system, and we have blood that has recently left the lungs and it's being pumped by the heart to our systemic tissues. What are the partial pressures of oxygen and carbon dioxide in oxygen-rich blood? And then that oxygen-rich blood is going to pass through a systemic tissue. What are the partial pressures of oxygen and carbon dioxide in the interstitial fluid surrounding those tissue cells? And then we can examine the partial pressures of those gases in oxygen-poor blood as it makes its way back to the heart, where it will be pumped once again to the lungs. So we will take this diagram piece by piece and examine external and internal respiration and the partial pressures of oxygen and carbon dioxide that determine loading versus unloading. Here we're zoomed in the upper left region of the diagram in the previous slide, and we can examine partial pressures of oxygen and carbon dioxide in the context of external respiration, gas exchange that occurs in the lungs. And that gas exchange is going to occur between alveolar air and blood that flows through pulmonary capillaries. So in alveolar air, we have a partial pressure of oxygen of 105 millimeters of mercury, and for carbon dioxide it's 40. And then in this oxygen-poor blood, the partial pressure of oxygen is 40 millimeters of mercury, and for carbon dioxide it's 45. So let's take these gases one at a time. These two gases behave independently. A common misunderstanding for students is that it's somehow a one-to-one swap between oxygen and carbon dioxide, and that is not at all the case. Oxygen does its thing, carbon dioxide does its thing. And by its thing, I mean move according to their partial pressure gradients. So let's take oxygen. We have oxygen-poor blood that's passing through a pulmonary capillary. And the partial pressure of oxygen in that oxygen-poor blood is 40 millimeters of mercury. And remember that pulmonary capillary is directly on the exterior surface of the alveolus. And so on the other side of the respiratory membrane is alveolar air. and the partial pressure of oxygen in alveolar air is 105 millimeters of mercury. So you can see the diffusion gradients here. Oxygen's going to move by diffusion from an area of high partial pressure to an area of low partial pressure. And so this partial pressure gradient favors oxygen loading as oxygen moves from a region that has 105 to a region that starts off with 40 millimeters of mercury. And then we can also examine the movement of carbon dioxide. Let's start here. Back in the blood, we have this oxygen poor blood. It's recently been to body tissues, and it has a partial pressure of carbon dioxide of 45 millimeters of mercury. So this oxygen poor blood arrives in the pulmonary capillary, and on the other side of that respiratory membrane is alveolar air, and alveolar air has a partial pressure of 40 millimeters of mercury. So the diffusion gradient, the steepness of the distance, is much less for carbon dioxide than it is for oxygen, but nonetheless, 45 is larger than 40. And so this favors carbon dioxide unloading, and carbon dioxide will diffuse across that respiratory membrane and it will join alveolar air. Here we're zoomed in on the lower right portion of that diagram, and it will allow us to focus on the partial pressure gradients that are present and that drive internal respiration. And internal respiration is gas exchange that occurs between blood in systemic capillaries and interstitial fluid, the fluid that surrounds our tissue cells. So let's take a look at our oxygen-rich blood that's arriving into a systemic capillary. Maybe it's a capillary that's passing through skeletal muscle tissue in your biceps brachii. And so we'll treat our two gases separately. The partial pressure of oxygen in this newly arriving oxygen-rich blood is 104 millimeters of mercury. And the partial pressure in our interstitial fluid of oxygen is just 40. Remember, our cells take up and use oxygen. And so the partial pressure of oxygen in the interstitial fluid is quite low. And so we have a pretty steep diffusion gradient. 100 is far greater than 40, and this is going to favor what's known as oxygen unloading. Oxygen will diffuse out of the blood and into the interstitial fluid, and from the interstitial fluid, it will diffuse across the plasma membrane and into our cells. Let's think about carbon dioxide. This oxygen-rich blood that's arriving in a systemic capillary has a partial pressure of 40 millimeters of mercury. And the partial pressure of carbon dioxide in our interstitial fluid is 45. Remember, our body cells are producing carbon dioxide as a waste product. Carbon dioxide is made during cellular respiration. When the cells make ATP, carbon dioxide is a byproduct. And so it's a less steep gradient, but it's a gradient nonetheless. 45 is bigger than 40. And this favors the movement of carbon dioxide out of the interstitial fluid and into blood that's in the systemic capillary. This is called carbon dioxide loading as carbon dioxide enters the blood. At this point in class, I would ask for a show of hands how many people have ever experienced altitude sickness. And typically 5 or maybe 10 hands go up, and we're all in a position to understand the physiology underlying altitude sickness. Why does it happen, and what can we do about it? So altitude sickness occurs, it's pretty common. It occurs when you ascend in altitude over a relatively short period of time. So you're going on a pretty intense hike and you're hiking up. You're ascending in altitude at a pretty fast rate. So here at 8,000 feet, altitude sickness can affect travelers. I experienced altitude sickness at about 10,000 feet, and now I have vowed never to ascend beyond 10,000 feet on a hike ever again. Altitude sickness is ultimately caused by the reduction in the partial pressure of oxygen in atmospheric air as we get further from the center of the Earth. So as you climb a mountain, for example, you're getting further and further away from Earth's center of mass. And this means that the atmosphere becomes less and less dense. As we get further away from the center of the Earth, the air molecules get further apart. And this has to do with gravity. You remember that a gravitational force is determined by an object's mass and the distance between the next object. So mass and distance determine gravity. And our atmosphere has mass. Those gas molecules have mass. But now those gas molecules are further away from the planet as we ascend in altitude. We're approaching outer space, and the air becomes less dense. There's a lower partial pressure of oxygen in atmospheric air at high altitude, and that causes the steepness of the diffusion gradient to decrease. So that's going to slow the rate of oxygen loading. We can revisit external respiration here, and you remember that external respiration is gas exchange that occurs in the lung. And we'll focus specifically on oxygen loading. That's the movement of oxygen from alveolar air into the blood, and that's driven by a diffusion gradient. So the values that are shown here, the original values shown here, are for air at sea level. And we can contrast that with air at 10,000 feet. So at 10,000 feet, the partial pressure of oxygen is roughly 110 millimeters of mercury. And that's going to influence the partial pressure of oxygen in alveolar air. At 10,000 feet, the partial pressure of oxygen in alveolar air is about 50 millimeters of mercury. And here we have our blood moving into a pulmonary capillary. There's no change from normal, from sea level conditions in the partial pressure of oxygen arriving into a pulmonary capillary. But now we have a far less steep diffusion gradient. Remember, at 10,000 feet, alveolar air has a partial pressure of about 50 millimeters of mercury. Well, it's 40 over here in that's arriving deoxygenated blood. So now at 10,000 feet, that diffusion gradient is determined by just 10 points, right? 50 versus 40. Whereas at sea level, it was determined by roughly 65 points, right? 105 versus 40 millimeters of mercury. So the steepness of the concentration gradient is much less when we're at altitude. This severely hampers or impairs the process of oxygen loading, and that leads to altitude sickness. How do we treat altitude sickness? Most obviously, go back down. So if you go back down, you'll re-encounter an atmosphere with a higher total barometric pressure and an atmosphere that has a higher partial pressure of oxygen, and that is often sufficient to alleviate symptoms. If possible, you can be supplied with oxygen-enriched air, and that will increase the diffusion gradient between alveolar air and blood that's in a pulmonary capillary, and that can also alleviate symptoms of altitude sickness. And another option is just to stay where you are and rest. So don't go up any further. And over time, your body can acclimate to the new conditions prior to your next ascent.